Okay, so we are going to just go over some real world examples of the bougie use in kids less than 5 to 7 years old. Start here. This looks like a Macintosh blade into the vallecula. Getting some good epiglottic lifting. Bougie goes in. Seems pretty straightforward. Maybe they could have gotten away without a bougie, but bougie worked great. And that's it. This looks like it's probably during CPR. And others feel free to jump in here, but bougie's going in okay. Do you always do the blade in the vallecula, always lift the epiglottis, or just do case by case, Anna? What are your...
So again, we can kind of talk about what classic teaching is. So classic teaching, when I was a resident, and when I say that it makes me feel old, but I learned to really only use a Miller blade and directly lift up on the epiglottis in kids less than 8 is what I was taught initially. And that's because that epiglottis is longer and floppier and omega shaped, so they say. And so the thought was that you couldn't really, that a MAC or sort of engaging in the vallecula wasn't enough to actually lift the epiglottis out of the way. I think the new research and new teaching is sort of it went from 8 to 2, and then even now there really hasn't been anything that shows that you can't use sort of a MAC-shaped blade or actually just engage the vallecula through almost all ages. So really, I think for our emergency practice, I'm using really a MAC-style blade for all of my peds, maybe down to the neonatal size, and traditionally trying to just engage in that vallecula and lift up in that way. I think if you struggle with visualization, you should be able to take that MAC blade and lift directly up on the epiglottis and use it like a Miller. But recent studies have shown no difference really between success rates with MAC and Miller in little ones. So that's my personal preferences.
Yeah, makes sense. I mean, no sense to be dogmatic and always have to do it one way or the other. Mm-hmm. If it works great for adults, like this is great exposure right now.
In these last 2 videos we showed, it's a good example of the space constraints in a pediatric airway, and they easily can fill up with fluids or fogging or other things that traditionally have been thought to be a challenge to video laryngoscopy, but here's 2 examples where the video still worked perfectly and facilitated bougie intubation.
Mm-hmm. And the nice thing with the MAC blade is if it did fog up to the point where you couldn't visualize, you still have the direct look.
Mm-hmm. Yeah, fluids are present in a lot of these cases, but they're doing a good job staying high and not going into a puddle. And sometimes, like in this case, it's, even though there are fluids, I think it's okay not to suction because you got a good enough view to pass the bougie.
And I think even though we don't have high quality data that bougie results in better intubation outcomes in this age group, I think like adults, you can see that passing a bougie doesn't obscure your view of the cords. It doesn't, like a styleted tube, you can really see unlike a styleted tube, you can see your bougie entering through the glottis and confirm you're in the airway, not the esophagus as you pass your tube.
So another straightforward bougie attempt.
So I think this is a good example because they're a little off the midline there. As you can see, the epiglottis flopping over to the right. They've got a good grade view here. They've got a grade 1 view, and then they get the bougie, and I think at some point you lose concentration of the blade, and the blade starts to back up, and they actually give themselves a worse view. And by the time they're backed up and the tube's passing through, they give themselves a grade 3 view. I think it's just important to remember to stay focused on that. And the bougie through doesn't necessarily mean the procedure's over, and to maintain visualization of that tube going through the cords up until the procedure's done.
I just want to note that Aaron got his grades correctly there. We've been giving him some flashcards on those.
Been practicing.
Nice work. All right, a couple more to go here. I think are good examples of the bougie. Again, this is like a younger patient.
And this is a flat blade, it looks like.
Yeah, so they had to pick up the epiglottis directly. It looked like the epiglottis was actually kind of harder to control there. And I think you can see here, when you use the Miller technique, or lift up the epiglottis technique, it does give you less space to pass things. So I think that's one advantage of putting it in the vallecula when it works. This makes it, I think, slightly harder. But you need to do it sometimes.
And one thing I think we teach when we're intubating kids that are preschool age or less is that because the tube depth is so important and we pay attention to that, the choreography between the intubator and the person assisting needs to be very good, because it's easy to accidentally extubate a patient when the bougie comes out or when you start to bag.
Absolutely. I think the intubator really should give the step-by-step instructions to the team. And people can be waiting for their instructions rather than trying to guess what they're thinking.
And if they're concerned about accidentally extubating when they pull the bougie, or true for the stylet as well, it's certainly preferable to, you can intubate a little bit deep and then pull back before it's secured to the right depth. So that would certainly be preferred if rather than be a little too shallow.
I see a corkscrew in there.
So there's a jaw spreader, which looks like it's in the middle of the mouth, which is maybe why they're entering erroneously to the side. I think it's causing more trouble. There's CPR ongoing.
And this looks like a Macintosh style blade. They're millering it, which is fine. Get to the view you need.
But I would ideally remove that corkscrew if you can. Just then, once you get it open, you should be able to use some other method to keep it open, at least if it's impeding laryngoscopy.
Anna, what are your thoughts on CPR pausing compressions versus not? Because we've seen two now, I think, where compressions seem to be ongoing throughout intubation.
I mean, I think if you've got a skilled intubator who can get it in when compressions are going, that's fine, but I don't think that pausing compressions is the right call. I think that generally kids are able to be either ventilated with a bag valve mask, like they don't have a beard and a bunch of stuff to compete with. So usually you can bag a kid or use a supraglottic where you're not actually stopping compressions. These examples show great ongoing CPR while intubation's in place. But I think, not stopping to get the tube in is reasonable.
Yeah, and Aaron published a paper on that, which I think supports that. And I think what we see in these videos is that, the bougie, well, maybe not strictly required in any of them, maybe it probably would have been possible. It seemed like it was very straightforward to access the trachea, pass the tube over it, and kind of do it just like we intubate for adults, which I think leads to more confidence, more success for these pediatric patients. So we don't intubate nearly as often as adults.